Good morning, everybody. This is Justin Dunaway here with the Institute of Clinical Excellence, and today I want to talk about a new commentary I just read called "We Need to Debate the Value of Manipulative Therapy and Recognize that we do not always understand from what to attribute our success." Right? This is a really interesting short commentary. I'll post the link in the paper, but it really got me thinking about a couple different things. On the front end of this, I'm going to say that, full disclosure, I teach spinal manipulation seminars and persistent pain management seminars for the Institute of Clinical Excellence. So you can kind of guess where I land on this debate, but I just want to throw some ideas and some nuance at this and see what you all think. So first off, I want to talk a little bit about some of the stuff that the paper said, and then we'll dive into it pretty deep. The first thing that they said that was pretty interesting is, I think that this came from some observations from the IFOMP conference and the AOMPT conference, where there was some debate about some different manual therapy techniques and manipulation occurring in some of the labs. And one of the things that was said, which is pretty interesting, is that a pain science conference broke out at a manual therapy conference. Right, so there's, as always, we in physical therapy, we tend to exist in these silos, and it sounds like it kind of came to a head where you've got your neurophysiology people here and your manual therapists there, and they're kind of battling back and forth about what's what. And I think it's really interesting that this was said, but I think this is a fantastic thing. I think that our manual therapy techniques can be launched from a foundation strong in pain neuroscience, from a psychologically informed approach. This is excellent that these two things are starting to mix. Another really interesting quote that was in this paper was, can we all admit that the correct treatment is one that gives the patient the most benefit with the least amount of harm? Right? And this is another fantastic thing, because we can argue all day long over this intervention versus that intervention, and what we find is that a lot of times different interventions work for different patients at different time points. So realizing that what we're doing is more about the patient in front of us than what our hands are doing seems to be really important. But the other interesting part of this quote is that it's about the most benefit with the least amount of harm. And we have to realize that harm can be more than just physical, right? Psychological harm can occur with our treatments, or our treatments can be done in a way that don't promote independence or resiliency. They promote dependence on the practitioner. And manual therapy gets a bad rap for this. And manual therapy can definitely be done in a way that creates a harm, and that harm is independence on the clinician. But manual therapy can also be done in a way, if we're careful with our wording, our explanation, and the context in which we deliver it, and the amount that we rely on it, it can be done in a way that doesn't create this harm, but actually promotes independence and resilience. So just something to keep in the back of our heads. Another thing that they mentioned here, and there's only two more quotes, and I'll dive into the meat of this. The exact mechanism of manual therapy is unknown, which I totally agree with that. And the non-specific factors are present in any treatment we deliver. So to use them to discount a favorable outcome is akin to suggesting that no treatments are effective. This is a really interesting sentence here. And when we say non-specific effects, it all kind of gets lumped together with this idea of placebo or non-specific effects, or the non-mechanical thing that occurs when we impart a treatment. What we know from the research is that all treatments have these non-specific effects. I'd love to get rid of the word non-specific altogether and just call them neurophysiologic effects. When we put our hands on somebody, when we impart a force into a human, there's something that occurs locally, and then there's this complex cascade of neurophysiologic stuff that occur at the cortex, the cord, and in the periphery, and all these mix together to create our outcome, right? And this exists in everything we do, whether it's manual therapy, whether it's exercise, whether it's education. Everything we do has these neurophysiologic effects. So to compare one treatment against something that's purely neurophysiologic, and then if they're equal, discount the treatment, what they're saying is that no treatments are effective if non-specific effects are a discounter. And that is a brilliant sentence. But kind of the last sentence, the last quote, and the way the paper ended, and the thing that really got me thinking about this topic is this last sentence. They say, let us move past the which is better debate in regards to clinical treatment and start respecting that our paradigms may require updating. Each individual patient is different, and every individual we treat deserves an evidence-based, multifactorial plan of care. And if we do not provide evidence-based, patient-centered care for our patients, someone else will, or maybe they already are. Right, and that's a really powerful statement there. And that's what I want to dive into. Somebody else will, or maybe they already are. So, what does that have to do with manipulation? We're going to get to that in a minute. But first I want to dive into this chunk about maybe they already are. Guys, when we look at the research for utilization of physical therapy for back pain, because that's the thing that's most studied, #1 cause of disability worldwide, so we're gonna stick with talking about back pain. When we look at utilization of physical therapy, Fritz in 2013 showed us that about 7% of people that enter the system with back pain end up in physical therapy. In another Fritz paper in 2013, we saw 13%. John Childs, 2015, showed us 16% of people that enter the system for back pain end up in physical therapy. Guys, these numbers, one, have been reproduced study after study, so they're probably relatively accurate. Number two, these are wildly abysmal. We're getting less than 10% of patients that enter the system with back pain, the most common cause of disability worldwide, less than 10% of that end up in our clinics. And we pride ourselves on being the providers of back pain care. We know spines, and we're not getting these patients at all. So what the authors suggest is that maybe they're getting care somewhere else. Well, obviously they have to be if the other 90% are going somewhere else, right? And why is this such a bad thing? We know that patients who enter physical therapy early with back pain, they have significant downstream effects that are fantastic, right? We know that early PT for back pain shows decrease, those patients, if we trace them down the road, they have decreased use of imaging, decreased physician visits, decreased surgeries, less injections, less opioid usage. The downstream effects for these patients are huge, which means we have to find a way to get the other patients in the door. They're going somewhere else because we haven't owned this space, right? So again, where are we at with manipulation? So when we look at, first off, when we think about this debate about manipulation, or the need to debate manipulation, if you just jump on PubMed right now and search spine and thrust and manipulation, you're going to get thousands of hits. And in these hits, you're going to find it's effective, it's not effective, it's safe, it's not safe, it's better than mobilization, it's not as good as mobilization, it's better than exercise, it's not as good as exercise. When you combine the two, they're great. When you combine the two, they don't do anything. What you're going to find is a mess of research that's not all done the same, and the outcomes are very wildly different. We can find a study or a handful of studies to support whatever our bias is when it comes to manipulation. But the one thing that we do see consistently throughout the research is that when we're talking about back pain, if we're looking at evidence-based guidelines, manipulation is on board. Whether we look at the physician guidelines in the US or the UK or anywhere else in the world, what they say is that for acute back pain, manipulation should be part of the package. For subacute and chronic back pain, we should be throwing manipulation at it with some other stuff. And even our own guidelines, we have our Delito guidelines from 2012 that say for acute back pain, we should be manipulating. For subacute and chronic back pain, this should be part of the package as well. But Wong in 2016 did a systematic review, and I'll throw the article in here, that looked at all the guidelines he could find, and then pulled out the ones that were the most evidence-based, and then looked at those to see what the most overlap was. What are the most common recommendations for patients with back pain, and what did he find? Well, first, if you have back pain, acute or chronic, you need education, reassurance, and self-management. 2, if you have acute back pain, we are going to encourage you to return to activity, and you may benefit from some low-level anti-inflammatories or some manipulation. Number 3, if it's got chronic back pain, we should be doing exercise and some low-level medications and manual therapy, multimodal rehabilitation, looking at physical and psychological treatment. So again, getting our hands on the patient seems to be important there too. And the last one that will take some people by surprise right now is that patients with lumbar disc herniation with radiculopathy may benefit from spinal manipulation. These are the evidence-based guidelines that are most common throughout the world when treating patients with back pain. So what the guidelines say is that we should be throwing manipulation, or it should be on the as part of the package, or it should at least be in our toolbox if we're going to be frontline providers of back pain, because that's what the guidelines say patients should be looking for. So when we go back and think about some of those numbers, maybe part of the problem is that the patient is looking to buy a bicycle, and the sign on our shop door says scooters only. We've got some bicycles in the back that maybe we pull out on Saturday if somebody walks in the door and asks for one real nicely, but we haven't really owned that space, right? So at the end of the day, back to the title of this article, we need to debate the value of manipulative therapy and recognize that we do not always understand from what to attribute our success. That second half of that sentence, I'm 100% on board with. Yeah, we do not know why patients get better when we do specific things. It's probably some combination of something locally mixed with this wildly complex neurobiological phenomenon that happens at all levels of the nervous system. And we're never going to be able to tease out exactly what that is. But when it comes to the need to debate the value of manipulative therapy, we've spent a lot of time and a lot of effort and a lot of research in this debate. And we've never quite solved it. But what we do know is that the guidelines expect that clinicians treating back pain are proficient at this. So what are we really talking about here? What we're talking about is an intervention that is incredibly safe. Depending on which literature you read, you'll find that cervical manipulation is anywhere, can be upwards of severe adverse event 5 to 10 times per 10 million manipulations. Incredibly safe. When we look at lumbar spine, it can be anywhere between 1 in 10 to 1 in 100 million manipulations to see a severe adverse event. Probably one of the safest things that we'll do in the clinic. When we look at some of John Child's research, what we find is that patients that are appropriate for manipulation and don't get exercise only, when we compare them to people that get manipulation plus the exercise, they have negative downstream effects. At 6 months, they're using more medications, they've gone to more doctor's visits, they've got more imaging, they've utilized the system more. They're doing all the opposite of what we're trying to get, right? So what we're really talking about here, without getting into the whole debate on the literature and the efficacy and all that, what we're talking about is trying to change a massive cultural change, right? What we're trying to do is say that, if we believe that manipulation is just anything else and we shouldn't be using it, what we got to do is rewrite every guideline. We've got to change the mind of every physician. We got to change the mind of lots of clinicians. We got to change the mind of lots of patients. We've got to change the minds of so many people to get them on board of saying, okay, let's not have this as one of the frontline treatments. Or we can get comfortable and confident at providing a 30-second treatment that we're going to follow up with some mobility and loading work, right? I mean, this is what it looks like in the clinic. John, let's put you in a position. I'm just going to put you on your side here. I'm just going to move you from here to here, give you a quick little stretch. When I'm done, you're going to sit up. You're probably going to feel better. Is that all right? Fantastic. All right. Done. Stand up. Let me see you move around. That looks great. Now let's head out in the gym and follow it up with some mobility work. We got things moving better. Let's keep running down this train. Great. Now let's pick some stuff up off the floor. Right? It's such a tiny piece of the treatment package that I really don't think it deserves all this time. But what we do know is that since every guideline out there recommends that it needs to at least be considered in the package, we should be much more comfortable and proficient at it than we currently are. So, at the end of the day, what we need to do, this should be in our toolbox, right? It doesn't mean that we're going to manipulate every patient through the door, but we should know it. We should be comfortable with it, we should be confident in it, and we should be proficient at performing this technique well, and we need to own this space, right? We need to be the people that fix back pain. Not because we actually fix things, because I don't believe that. I think we come alongside the patient and guide them along this path, but that's not what patients want to hear, right? We need to meet the patients where they need to be met. We need to meet the referral sources where they want to be met. We need to meet the culture where they want to be met. Get them in the door. And then we can start doing all of the awesome things that physical therapy does, right? Which is going to be finding any way we can to come alongside the patient, to leverage your beliefs and expectations to drive you into a stronger, healthier lifestyle that promotes independence, resilience, and internal locus of control. And if I've got to manipulate your back to get you in the door to do that, then fantastic, we should do it. But we need to own the space if we want to move that 7% up higher. All right, very good. That's all I got on this this topic. I'm gonna post a couple of those articles in the feed here. If you haven't yet checked it out or registered, the Demystifying Dizziness course from Institute of Clinical Excellence by R.J. Williams. This weekend, the inaugural course will be in Portland, Oregon. This is a not miss course. So if you guys are in the area or don't have plans yet this weekend, get to Portland, see R.J. do his dizziness thing. Otherwise, guys, have an awesome Tuesday. Go out in the clinic or the classroom or wherever you're at and rock your day. If you have any questions, just post them below.